Thank you very much. I'm very happy to be here with all of you, many of you friends. And basically, my talk is a real practical one because we all know we are in a world that we're going to see many more patients. The population is getting older. We are getting older too. And we need to give attention to all these patients. I come from a country where we have a public system, so I get a salary to see my patients, and many of you might be feeling that, oh my God, that's horrible. Well, I can tell you a beauty about that system. It's a democratic system where all patients go to bed at night with the peace of mind that they know that if they have a health issue, they can go to the doctor next day. So yes, I love working in my public system. And, but still, I'm one person and I have to take care of a population of 65,000 people. And, I work with farmers and sailors. So I get, they have a lot of skin damage. So I do have a tsunami of patients. So we implemented teledermatology in my hospital over 15 years ago, so way before COVID. And actually, I cannot live without telederm because I do need to get my images through telederm. The incidence rate is probably as high on cases as you get in the States. And telederm is the one that has allowed me to see the patients and reduce my waiting list. But probably the most important thing, since I take care of the oncology part, is that it has allowed me to prioritize. I find it, interesting, all this conversation about can we include a teledermoscopic image? I find it, of course you can. I mean, it's an image. I mean, I don't really understand the issue of why in some countries you cannot add the teledermoscopic image. I simply do not receive any consultation that has no dermoscopic image. If there is a new family physician and is not sending the teledermoscopy, then they, go back and take the image because I take no decisions with both images. And so that's what my patients do. They go to their family physician. I have trained them for some time, and so they know they have to take a good clinical image, still an issue sometimes, dermoscopic image, and just a few words saying, this is a tumor, so many years, so many months, and then they send it. And I've been looking at what people are writing about the teledermoscopy assessments and all that. And basically, I always tell people that do telederm, if you're not sure, just tell the patient to come in. What's the big issue? I mean, oh, the image is not good. Okay, have the patient come in. That's the worst scenario. And usually the tendency for doctors that do telederm is that if you don't see something that is not clear, you have the patient come in, that's it. Because you're not gonna run any risks. So you have, for me, that's not really the problem. And these are some of the images my family physician sent. So obviously, I'll take care of that. That's a BCC, and I'll have the patient come in prioritized. My patients come in a week, maximum 3 weeks if it's a BCC. I'm not going to speak about melanomas here, but if it's a melanoma, for sure, it takes hours to a week maximum for a melanoma patient to come in. Now, once they come in, I usually work with a high frequency ultrasound. I love it because it gives me morphology. It tells me how deep a tumor is, how big, the shape it has. So I take decisions on what I have to do based only on the morphology in this case. So it's a BCC by dermoscopy, and it's very roundish. It looks like a dermoscopically as a nodular tumor. Then I can decide what to do with the tumor. Do I do surgery? Do I do a minimally invasive technique? And it works very nicely because just with the shape you get a lot of information. And this is something we published some years ago regarding 100 tumors and the capacity we had with a high frequency ultrasound to determine the histological subtype. Another thing that I published many years ago is that I do ex vivo ultrasound, which means I shave the tumor and I see if I have removed it completely because I put it again in a gauze and I do an ultrasound. And I tell the pathologist, okay, I'm sending you a tumor-free margins. And the pathologist, this lady, she's always, But then at the end, it worked out because we did many tumors, double blind with 2 pathologists. And I can tell just by shaving a tumor if I have removed the whole tumor. And it's great because for small tumors, you don't even have to do surgery. You just shave them out. I do a lot of minimally invasive techniques. That's why I go around the world. It's like my crusades, personal crusades, for people not to forget about techniques like cryosurgery, because you can do so much with cryosurgery. And I do tiny tumors, I do huge tumors, and it works fantastically if you do it correctly. And I just wanted to bring you, I've been doing a retrospective analysis of the tumors I removed from 2016 to 2019, which is 4 years, right before COVID. And all these tumors had biopsies. So, these numbers are very similar probably to all of the ones you get. 70% were BCCs and 30% squamous cells. And interestingly, half of them came through telederm. The other ones were patients that just, the patients I see regularly because they have a lot of skin damage. But half of them were priorized through telederm, which is fantastic. I mean, they had their tumors removed in a week or 2 weeks. And that's not brain science. I mean, if you get the patient come in earlier, it's a smaller tumor than if you wait 2-3 months. These are the techniques that I have used to treat those tumors. And as you can see, I basically, 75% of my tumors are treated with minimally invasive techniques. And I know that for a country that does a lot of Mohs surgery, this is like, what? How many $1 million have you done? Well, yes, I've spared the system a lot of money, because basically you do not need to do Mohs surgery on most of the tumors, which is a fantastic technique, by the way, fabulous, incredible. But you have to select patients because not everybody needs a Mohs surgery. You can do many other things. And so this is just to show you graphically how most of the tumors that I treat, I just do it with non-invasive techniques. And then you say, oh, okay, probably you have a huge recurrence. Well, you can see here that, my cure rates for cryosurgery are 97%. I mean, it's like basically the same ones as you get with surgery. But then I checked what I did with all those tumors, which were here I have 886 tumors, and I had like 60 tumors that had recurrences. And of those that had recurrences that were treated with minimally invasive techniques, in most of them, I did another minimally invasive technique and they were cured. So basically my complications come down to 12 patients, which is, I think, the same numbers you get even doing surgeries, because there are certain tumors that are aggressive and that might need sometimes even more than one Mohs surgery. So this is my conclusion, that over 4 years, I treated 886 tumors, 50% came through telederm, and in 75%, I treated them with minimally invasive techniques. Needless to say that most patients are over 70, and that, the older you get more tumors. And that, given the comorbidities that many of these patients have, they're really happy of not having invasive techniques for their treatments. In fact, I have patients that, have one tumor and then another and then another. They just come in and they say, do the minimal, because I have already had 10 BCCs taken out. So I, depending on the tumor, because morphology is not the only aspect to take into account, but, I try to do as many non-invasive techniques on them. And this is basically what I wanted to say. With teledermatology, yes, I do need artificial intelligence. So you, the experts, please, because I'm still in a situation where I have a one-to-one relationship. It's one patient, one teledermatologist. It's not, very practical. I need to have 100 consultations and then just see one, because many of them could be taken care of by artificial intelligence. We get better images. That's my other crusade. I teach photography around, all congresses. I'm always teaching something so basic as how to take a good image, because we need good images. And then finally, teach minimally invasive techniques, because we can do so much for our patients besides doing surgery. Thank you very much.